Hello and welcome. Today we'll be discussing analgesic nephropathy, a serious kidney disease often linked to long-term painkiller use. Understanding this condition is crucial for both healthcare professionals and individuals who rely on pain medications. Let's delve into the details. Analgesic nephropathy at its core is primarily caused by the chronic and excessive use of over-the-counter or prescription pain relievers, particularly those containing combinations of multiple analgesics. Historically, phenacetin was a major culprit, but it has largely been withdrawn from the market. Current risk factors include long-term and high doses of non-steroidal anti-inflammatory drugs or NSAIDs such as ibuprofen and naproxen, especially when combined with caffeine or codeine. The risk is significantly increased when taken over many years, and even more so in individuals with pre-existing kidney conditions or dehydration issues. The damage in analgesic nephropathy occurs primarily in the kidneys. The prolonged exposure to analgesics, specifically metabolites of these drugs, causes damage to the tubules and the interstitium of the kidney. This leads to a gradual process known as chronic tubulointerstitial nephritis. The small blood vessels within the kidneys also suffer, leading to papillary necrosis, which is the death of the renal papillae. This impairs the kidney's ability to concentrate urine, filter waste products from the blood, and maintain electrolyte balance. Over time, this progressive damage can lead to chronic kidney disease and, eventually, kidney failure. The exact prevalence of analgesic nephropathy is difficult to determine due to underdiagnosis and changes in analgesic use patterns. It was more common in the past when phenacetin-containing medications were widely available. However, it still occurs, especially in individuals who chronically use NSAIDs for conditions like arthritis, chronic headaches, or back pain. Certain populations, such as women and individuals with a history of mental health issues or substance abuse, may be at higher risk. The occurrence varies geographically depending on analgesic usage patterns and prescribing practices. The signs and symptoms of analgesic nephropathy can be subtle in the early stages. Individuals may experience fatigue, increased thirst, and frequent urination, especially at night, a condition known as nocturia. As the disease progresses, symptoms may include edema or swelling, particularly in the ankles and feet, high blood pressure, anemia, and flank pain. Eventually, if kidney failure develops, symptoms can include nausea, vomiting, loss of appetite, and shortness of breath. It's important to remember that these symptoms can also be related to other medical conditions, so a proper diagnosis is crucial. Diagnosing analgesic nephropathy can be challenging because the symptoms often develop gradually and are nonspecific. Diagnosis relies on a combination of factors. A thorough medical history, including detailed information about analgesic use, is essential. Blood tests can reveal elevated creatinine and blood urea nitrogen, indicating impaired kidney function. Urine tests may show proteinuria, the presence of protein in the urine, and hematuria, or blood in the urine. Imaging studies, such as ultrasound or CT scan, can help visualize the kidneys and identify abnormalities like papillary necrosis or small kidneys. A kidney biopsy can provide a definitive diagnosis, but it is not always necessary or feasible. There aren't specific types or formal classifications of analgesic nephropathy beyond the stages of chronic kidney disease, CKD, that result from it. The severity is usually classified based on the glomerular filtration rate, GFR, which determines the stage of CKD. Stages range from stage 1 with normal or increased GFR to stage 5, which represents kidney failure and requires dialysis or kidney transplant. The primary goals of treatment and management are to stop further kidney damage and manage the complications of chronic kidney disease. The most crucial step is to immediately discontinue the use of the offending analgesics. Supportive care includes managing blood pressure, controlling blood sugar levels if diabetes is present, treating anemia, and addressing electrolyte imbalances. Dietary modifications, such as limiting protein and sodium intake, may be necessary. In advanced stages of kidney disease, dialysis or kidney transplantation may be required to sustain life. Prevention is key to avoiding analgesic nephropathy. Individuals should avoid chronic, high-dose use of analgesics, especially combinations containing multiple ingredients. Always follow the recommended dosage instructions on over-the-counter medications and consult with a healthcare professional before starting any long-term pain management regimen. Consider alternative pain management strategies, such as physical therapy, acupuncture, or other non-pharmacological approaches. Regular monitoring of kidney function is recommended for individuals at high risk, such as those with pre-existing kidney conditions or those taking long-term analgesics. The prognosis for analgesic nephropathy depends on the severity of kidney damage at the time of diagnosis and the individual's adherence to treatment. Early diagnosis and cessation of analgesic use can significantly improve the outcome. However, irreversible kidney damage may have already occurred, Recent research has focused on understanding the specific mechanisms by which analgesics damage the kidneys, as well as identifying potential biomarkers for early detection. Some studies are exploring the use of renoprotective agents, such as ACE inhibitors and ARBs, to slow the progression of kidney disease. Further research is needed to develop more targeted therapies for this condition. Thank you for watching, and remember to consult with your doctor about any concerns related to pain medication and kidney health.